Doctor, what is your name? Sorry. Dr. Shanti.
Yes, sir.
Yeah. So now we are taking a one-to-one session with Dr. Shanti, and Dr. Simply is also there. There are many candidates, but we have unmuted only two. You have completed the early pregnancy. Now somebody has posted a question before taking the session. Somebody has posted a question: how to put a jelly in a condom when taking a transvaginal ultrasound. Now a kiddish question, but we will show you how to put this also. So please post relevant questions. How to put a jelly in a condom. This is how we are putting it. See it yourself. Taking a condom over there this way and putting a jelly like this, and putting the probe in the jelly. So dipping in the jelly. Now see, dipping in the jelly and wrapping off the condom on the transducer. So this is how we are putting the jelly while using the transvaginal ultrasound. So this question has been also taken. So I again request you to post relevant questions. Dr. Shanti.
Yes, sir.
Now we will take a live patient session of early pregnancy. This is for those who are beginners. Now, this is the uterus over here. The probe used is transvaginal ultrasound, and this is the cystic-like lesion over here. What is this over here, Dr. Shanti?
Ji, sir. So
Why this is gestational sac? Why not a cyst over there? Why not a cyst over there? Why a gestational sac?
Decidual reaction around the cyst.
Very good. Now see the lifetime scanning. The decidual reactions over there. So what are the decidual reactions? Decidual reactions, these are the decidual reactions. Those who have not seen the decidual reactions, this is the decidual reaction over here. This is the decidual reaction. This is a very small gestational sac. This is a very, very small gestational sac. This is picked only on TVS. On TAS, it can be easily missed. So this is the case of very early pregnancy. Please control your background noise. And this is the gestational sac. Why this is gestational sac? Because there are decidual reactions. And how the decidual reactions are looking like? This is the decidual reaction. Decidual reactions will be hyperechoic. It will be hyperechoic. So this was the first case. So now the second one. Next patient. Now, Dr. Shanti,
yes,
this
sir.
is the gestational sac, and here the probe used is transabdominal. This is the transabdominal probe used over here. You can see,
sir.
This is the transabdominal probe, and this is the gestational sac over here. What I am seeing next to the gestational sac, this area. What this can be. Please control your background noise. Otherwise, we'll remove you from the class.
Sir, double decidual sac sign.
Double decidual sac. Very good. Remove that person. Not Dr. Shanti. Another one. So this is the gestational sac over here. This gestational sac is having a good decidual reaction. So this is the decidual reaction, and this is the unobliterated uterine cavity. This unobliterated uterine cavity. Why, Dr. Shanti, this is important?
Sir,
these things are discussed with you during the class. I'm just giving you a quick recap.
To rule out pseudo sacs.
Very good. Because this thing, this unobliterated uterine cavity is telling me that, doctor, you are not dealing with an ectopic
Pseudo-
pregnancy. I mean the pseudo-gestational sac. This is a true intrauterine gestational sac. So this is the importance of this unobliterated uterine cavity.
Yes,
So
sir.
here comes the decidua parenitalis, decidua capsularis, which is already discussed in great detail with you. So this is the unobliterated uterine cavity. Now, how the yolk sac is looking like? Now see, first of all, how to take the CRL. CRL has to be taken from this point to this point. And the important point is that the fetus should not be in flexion, not in extension. So this is the point, first point, and this is the second point. So this is the CRL, crown rump length. And the importance of taking crown rump length is that crown rump length is more informative when I'm talking of this gestational age. It is more informative and more, not informative, accurate than even LMP. So if at any point of time, I mean in second or third trimester, you are confused with the EDD, you can go back to CRL and you can see how much it was corresponding and what was the EDD as per CRL. So CRL EDD, I mean the gestational age as per CRL, will stand its superiority till the term. So anyhow, this is how the CRL has to be taken, neither in flexion nor in extension. So now this is the gestational sac over here. Gestational sac has to be taken in measurements have been taken from the gestational sac. Dr. Shanti, how I can take 3 measurements from here to here first, second from here to here, and third from here to here. Yes or no? Hurry up. Yes or no? Hurry up. Yes or no? How can we take 3 measurements when I am talking of the mean sac diameter? Mean sac diameter. Dr. Samely, Dr. Moto, who is this? Reputed person. So the point is that whenever I am taking the crown rump length, the crown rump length will stand its superiority in prediction in terms of the EDD. And when I am talking of this mean sac diameter, what I have to take? I have to take 2 frames, one of the transverse section and one of the longitudinal section. From transverse section, I will take anterior posterior and the width, and in longitudinal section, I will take the length. Then I will take the mean sac diameter. So the mean sac diameter is the mean of 3. So 3 is anterior posterior, width, and the length. That is for mean sac diameter. So this is how we are taking the CRL. Now see, the CRL is from here to here. Then you can zoom the image, and on zooming, you can clearly see your starting and the ending point. And this is the fetal heart over here. Now see, the fetal heart is over here. I will go to the M mode now, M mode. So this class is for just those who are beginners, who have just started. Then I will go to the M mode and I will see these pulsations. How to take? I have to take it on alternate basis. What I mean by alternate basis, you have to take first, you have to skip the second one, and you have to freeze on to the third pulsation. So then on setting, a pop-up will appear over there of the fetal heart rate. And how much the fetal heart should be, you have to again correlate it with the CRL to say whether I am dealing with a normal or abnormal fetal heart, and how much is normal for which CRL, how much CRL. I am giving you a rough idea because this is already taken again in your course. Now see, this is the yolk sac over here. Then I will measure the yolk sac. From this point to this point, I will measure. Why I have to measure the yolk sac? Because the yolk sac, if enlarged, is also an abnormal size. So the yolk sac should not be more than 6 millimeters, and it should not be less than 2 millimeters. And coming back to the fetal heart, how much the fetal heart should be? Fetal heart has to be correlate with the CRL. And if CRL is less than 5 millimeters, it should be more than 100. Please note it down. It should be more than 100. And this is how we are measuring the yolk sac. Now see, this yolk sac is on the higher side. It is about a 6. It is touching the 6. So this is 5.7, 6.4. So this is not a healthy yolk sac, because this is touching 6 millimeters. So coming back to the fetal heart has to be correlated with CRL. I will not worry more with tachycardia, but I will worry with bradycardia. So please note that the CRL, if less than 5 millimeters, the normal fetal heart should be more than 100. I'm repeating, if CRL is less than 5 millimeters, it should be more than 100. And if it is below 80, it is abnormal. In between 80 and 100, it is borderline. And if the CRL is in between 5 and 9, it should be more than, the fetal heart should be more than 120. And if it is less than 100, it is abnormal. In between 100 and 120, it is again borderline. And as the CRL is increasing from 10 to 15, then it is, the abnormal is 110. So 110 will be abnormal for 10 to 15. I'm repeating now from the start. CRL, if less than 5 millimeters, and fetal heart rate, if less than 80 beats per minute, is abnormal. CRL in between 5 to 9, the abnormal is 100. Less than 100 is abnormal. And CRL in between 10 and 15, heart rate of 110 is abnormal. So you have to correlate this way. So now again showing you how to take this CRL from this point to this point, how to take the gestational sac. You have to divide the screen in two. There is a dual image. You have to take the dual image. Then you have to take 3 measurements, and that will give you the mean sac diameter. And regarding the fetal heart, you have to take in M mode. Then you have to, you have to take one pulsation, you have to skip the next one, you have to go to the third one. So from this point to this point, then you have to freeze it over here, and a pop-up will appear over here stating that I am dealing with this much of the fetal heart. Now in this case, it is 161, absolutely normal. So this is not a fetal bradycardia. This is an absolutely normal 160, and 160 is normal for any CRL, be it less than 5, be it less than 9, be it in between 10 to 15. So anyhow, this is not a 5 millimeters, this is more, but anyhow, this is a normal 161. This is how we are taking the fetal heart rate. So again, demonstrating and repeating, don't take it too pulsations, you have to skip one. But in some machines like Philips and some models of Samsung, you have to take it without skipping, I mean without alternate from first to second. So you have to see to your machine, and in about 90% machines, you have to skip the one, I mean on alternate basis. So now see, in this case, I am seeing an enlarged yolk sac. This is the enlarged yolk sac. And see to the decidual reaction. Decidual reactions are not healthy. Now, how much is the decidual reaction? More than 2. It should not be less than 2. Less than 2, decidual reaction is abnormal. Now, in this case, what I see, increased yolk sac with decidual reaction, which is not very good. So I will follow this patient for sure, because this is having a increased yolk sac with not satisfactory these decidual reactions. But the good point is that 161 is the fetal heart, which is absolutely normal. Now see, again, I'm measuring it again to confirm that. Now see, again, it is 6.4 over here. Now this is the third case over here. Sometimes you can confuse with this knuckle translucency. these things are already taken with in your course. I'm just giving you some important cases over here. I'm discussing this because people can comment blunder, except especially those who have just started their career. And now see over here, this is the area which can be mistaken for the knuckle translucency. And if you see this knuckle translucency, if you label this as knuckle translucency, you are committing a blunder. Why? Because you are not keeping amnion in your mind. You may be cheated by an amnion, and it will look like that you are dealing with an thick NT, I mean an increased NT. So make sure that you are not dealing with an amnion. You are not hitting the amnion. How to differentiate? See to the fetal movements, and with fetal movements, this will stand over here. This will not be taken by the fetus because this is an amnion. Amnion is not a part of the fetus, which is already discussed in your class, but on movements, on fetal movements, you will see that this will not move if this is amnion. And if this will move with the fetus, then you are dealing with a increased knuckle translucency. Now let us wait for the fetal movements. If fetal movements will happen, I have to wait. I have no other way, but I have to wait for the fetal movements to see whether this is a knuckle translucency or I am hitting amnion. So let's wait for now. See, this is the point which I discussed right now. With fetal movements, this will not move with the fetus because this is amnion and is not a part of the fetus. And if the fetus will take this with the fetal movements, then yes, I am dealing with the this NT, increased NT. So don't overdiagnose a case. This is the point. So fetal nose is over here. So not clearly in this plane. Now this is coming in between. And the important point is that don't see the fetus is waving on you. And don't measure this because this is the nasal tip over here. Nasal bone will be over here. This is the nasal bone, and that was the fetal nasal tip. So we are right now discussing this amnion. So and we are waiting for the movements if it will happen. Previously it happened, but I want to see it more clear. So let us wait for fetus is not moving. Come on, Jack. Move. Is not moving. So let us wait. So anyhow, this is the fetal heart over here, and this is the complete, not complete, but it is a mid sagittal section, not a very complete over here because I'm not seeing the spine in complete length. But here I am hitting. Why I am showing you this? Because here in this plane I am hitting. Now see this is the beauty. When the fetus is moving, this is not changing its position. So this is the point. Don't overdiagnose a case. Wait for the fetal movements till it happens to see whether I am dealing with a knuckle translucency or a amnion. So now what we will do, we will take some pictures very quickly, going through some of the pictures of early pregnancy ultrasound. What I can see over here is the gestational sac over here, and this gestational sac is in the adnexa. And this is the corpus luteum over here. I told you in the class that if you see two sac-like structures, I mean the cystic structures on one side only, I mean on the right or on the left side, then one has to be a corpus luteum and another has to be an ectopic gestational sac. Because the corpus luteum is nothing, this is the corpus luteum is nothing but a left behind ruptured follicle. So if I see two cystic structures on the same side, then I am dealing with the this ectopic gestation. Now see the probe here used is the trans-abdominal probe. Even I can see the yolk sac over here, yolk sac. So yolk sac is confirming me that I am not dealing with a cystic structure, but a gestational sac over here. So then zooming the picture, showing me a very clear this embryo, also very small embryo, and this is the fetal heart over here. So this is the live ectopic over here, and see to the fetal heart rate 102 over here, and see how we are taking the fetal pulsation, skipping the one and taking the third one in account, so on alternate basis. So again, this is the ectopic pregnancy, and on color investigation, this is the gestational sac for sure. Why this is gestational sac? Because I am having here trophoblastic invasion, and the trophoblastic invasion has been shown over here by the increased vascularity over here. And if somebody wants to take a pulse wave over here, it will show me a high diastolic flow. So now see, this is the diastolic flow, high diastolic flow. So this we call the placental flow over here. This is not actually the placental flow. Why this term has been coined over here wrongly? The placental, it should be a trophoblastic flow like over here, not the placental flow. Anyhow, the books are writing the trophoblastic, the placental flow over here. So this is how the placental flow is looking like, confirming the diagnosis of an ectopic pregnancy. So this is the gestational sac, and this is the CRL. So for freshers, how to take the this mean sac diameter, assume that this is the gestational sac over here, and this is the gestational sac onto the second side of the monitor, I mean on the right and the left. Take from this point to this point, and from this point to this point, and then from here to here. That will give you mean sac diameter. I'm just taking the example over here. This is actually the ectopic pregnancy, but how to take a mean sac diameter, I told you, you have to divide your screen in two. You have to put sac over here and here. One will be the transverse section, one will be the longitudinal section. Take two measurements from here, one measurement from here. That will be mean sac diameter. And now coming back to the case, this is the ectopic case over here, where we can see the fetal pole, but the point is not always we are seeing these clear cases of ectopics, but mostly we are seeing the cystic mass over here, solid mass sometimes. How to differentiate, we have discussed that in our ectopic class. So what I will suggest you to go back to the ectopic classes. There are about 4 to 5 ectopic classes over there. For revision purposes, please complete these ectopic classes over there. Now, yes. Now, what is this over here? So first of all, this is the gestational sac over here. This is the gestational sac. I am repeating this for the freshers only, for the beginners only. The CRL has to be taken from this point to this point. What I am hitting over here is the amnion. This is the amnion, and this is the future placenta. Now see, this is the future placenta over here. So this is the chorionic frontosum. And if why this is important, you know, we have taken about 2 classes about the hemorrhage, and if hemorrhage at this point is more dangerous than this point. So if it is detaching the future placenta, that is more dangerous than the chorionic leaf only. So see to the hemorrhage, to the detachment with respect of to the future placenta, that is the chorionic frontosum. That is already discussed in your class. So now we are showing you only the pictures. We are not discussing the cases over here. So this is the point. This is the chorionic frontosum over here. So this is the developing placenta. The hemorrhage at this level is dangerous. So this is how the yolk sac is looking like. This is the yolk sac. You have to measure this yolk sac, and this yolk sac should not be less than 2, and it should not be more than 6. And this is how we are taking the CRL. Somebody posted me how to take the CRL. You have to take the CRL in a complete mid-sagittal section. See to the complete length of the fetus and measure from crown to rump. Crown is here, rump is here. So this, don't include the limbs. This is the point. Don't include the limbs. Now see, these are the limb buds over here. You have to measure from this point to this point. So this is the crown and this is the rump. So don't include the limbs over here. That is the point. Now this is the complete length of the this fetus. Now, how to say whether the fetus is flexed or extended? See to the neck, see to the chin, not the neck, see to the chin. And if chin is elevated, then it is extended. If chin is dropped, then it is flexed. Now, automatically, you can make out if it is flexed, if fetus is flexed, then CRL will be less. And if fetus is extended, then CRL will be more. So see to the chin. And if chin is dropping and touching the chest, then the fetus is
Flexed.
flexed. Very good. So now see over here. What is over here? I can see the gestational sac over here, but this gestational sac is not regular. So it looks like it is collapsing. It is collapsing. And see to the decidual reactions. I cannot see very good decidual reactions over here. So this is an abnormal sac. Now, how much should be a gestational sac so that I can see the embryo? Now, please note it down. On TVS, on transvaginal ultrasound, the cut is 16 millimeters, 16 millimeters. With 16 millimeters, you should see a fetal pole in a gestational sac on TVS, and on TS, it is 25. It is 25. Jyoti, it is 25. And to see a yolk sac, get it here. To see a yolk sac, the gestational sac should be 8 on TVS, and on TS, the cut is 20. I am repeating now. Let me have coffee. Oh, is it hot or cold coffee? Wait. Keep it here. Now I am repeating. Gestational sac should be 8 millimeters, more than 8 millimeters, and you should see a yolk sac on TVS. And on TS, it should be more than 20. And if it is more than 20, you should see a yolk sac. Now coming to embryo. Embryo should be seen if the gestational sac is 16 and you are on TVS, and if you are on TAS, then the cut is 25 millimeters. And fetal heart. Fetal heart should be seen if CRL is more than 5 millimeters. Please note these points. These are very important. By this, you can only decide. 5 millimeters and more, if CRL, you have to have a fetal heart. Okay. So the decidual reactions here, coming to the case, are poor, very weak, and the eggs are collapsing. So this is an abnormal gestational sac. So what are the criteria of the abnormal gestational sac? This is the abnormal gestational sac. If you are not seeing the fetal pole, if you are seeing a fetal pole and you are not seeing the fetal heart, then again, this is an abnormal fetal, this gestational sac. And if the CRL is more than 5 millimeters, and if it is less than 5 millimeters, then you can give a benefit of doubt that I am not able to see for this particular point, that you can follow that case. Now the RPOC, if you see a hyperechoic area, first of all, the hyperechoic area, it will be hyperechoic. Now, how to differentiate whether I'm dealing with a hyperechoic area, from a this RPOC from a blood clot. Here, the master is color. Color is the master here. Without color, you cannot decide. So put your color, and if you see the color over here, if you see the color, then it is RPOC. It is retained product, because there is some trophoblastic invasion still. That is why I am able to see these flows, this vascularity over here. And if there is no vascularity, then it is a blood clot. Now, gynaes know the importance of differentiating, because that will decide the strategy of the treatment also. Now, again, the trophoblastic invasion will give me the placental flow over here. confirming that the above structure, the lesion is the RPOC. So with time, with experience, you will be able to take the flow from these vessels of RPOC, and if you see a high diastolic flow, that means the low resistance. If you have not taken yet the color Doppler, you will not understand the low resistance and these S by D ratios. And when you will take the color Doppler with us, then you will understand that what is a low resistance flow. Low resistance flow means high diastolic flow. So anyhow, this will come with experience. But to start with, you can put color only, and the color will decide if present RPOC, if absent blood clot. And later on with experience, you will be able to take the flow velocities, and if there is a typical low resistance flow, that means a high diastolic flow. Again repeating, if you are not understanding this point, you will understand this low resistance, high diastolic, what is that, when you will take color Doppler course with us. Okay, now this is the hyperechoic lesion, the mixed echo texture, I will say, which is showing me the flow, I mean the color, on putting the color Doppler. So now see, this is again the gestational sac, looks a normal gestational sac. Why normal? Because I am not seeing that the eggs are collapsing. Why this is very clear? Because the probe used over here is transvaginal. I can see the embryonic disc over here. We call it embryonic disc, very small fetal pole, embryonic disc, or a fetal pole also you can make it. But so any of this is the embryonic disc, and this is the yolk sac over here. For freshers, I'm repeating, don't take from here to here. That way you are including the yolk sac. So see to the rump, and from the this crown to rump only. So it will be from this point to this point, not up to the yolk sac. So see to your yolk sac. Sometimes the yolk sac is very close to the fetal, I mean this embryonic disc. So see to the fetal, this yolk sac also, because if you will not make out that this is the yolk sac, you will measure CRL from this point to this point, and that will be more. So now, very good case. Now see over here, the distal reactions are there. Yes, distal reactions over here. What is this over here? This is the detachment, not the unobliterated uterine cavity. How can I say that this is detachment, not the unobliterated uterine cavity? Because first of all, if it is unobliterated uterine cavity, then why there are some echoes over here? Why there are some echoes? And if there are echoes, it means that this is not a clear space. It has to be a detachment. Point number first. Point number second is that the patient was bleeding. And the third and most important point is that if I will rescan that patient, and if it is an unobliterated uterine cavity, in rescan, will it increase, decrease, or remain same? Think. Those who are thinking that yes, this will decrease, they are right. Because with increase the gestational sac, it will take more of the space. So the unobliterated uterine cavity will decrease. And if it remains same or increase, then it cannot be unobliterated uterine cavity. It has to be a detachment only. So these things are already discussed in your course. I am just giving you a quick recap of the important points over here. Those who have not taken the class till now will not understand everything, whatever I am discussing, I am repeating. If you are not taken our course till now, or have not completed the course, you will not understand what we are discussing, because these points, this is the theory first, which will make you understand these pictures, these cases. Okay, so again showing you the detachment. This is the detachment. This is the detachment. Now this is the chain. Now see, this is the chain. this chin is not touching the chest. If this chin will touch the chest, then the fetus is flexed. So this should make a 90 degree with the chest. And if it makes 90 degrees, see to your and my chin also, it is making a 90 degree over here. So if my head is like this, extended, then this will make an obtuse angle. So see to this chin, and that will decide whether the fetus is in flexed or in extension. So molar pregnancy. In molar pregnancy, this is the case of the molar pregnancy, where I see a snowstorm and there is no fetal pole, but there can be a partial mole also, where I can see the fetal pole. But in a classical mole, I see the picture like this, multiple cystic structures. And if I put a color, none of these cystic structures will take color because these are not vascular. So this is how we are taking the volume of the detachment. Volume of anything has to be taken on two. One is transverse and one is longitudinal. So this is longitudinal over here. This is the transverse. So first measurement in longitudinal, second from here to here, this is anterior posterior, and this is from right to left, that will be the width. And in physics and machine settings, we discussed in detail how to take this volume. So this is how we are taking the volume. See, what mind is not knowing, eyes cannot see. What is this? Now you can make out that this is the vitelline duct. This thing we discussed in the early pregnancy ultrasound, that this yolk sac and the embryo is not in the same cavity. One is in amniotic cavity and another is extra-amniotic. So both are connected by the vitelline duct. Why I am able to see this very clear over here? Because I have done with my settings. What is the setting over here? First is the depth. Now go back to the physics and machine settings course. Go to the class of probably 7th or 8th class over there. Depth versus frame rate. So this is the frame rate which I have to keep on eye. 45 is the frame rate. Why this is 45? Earlier it was low. It was 5 or 6 only. Why? Because with increase in the depth, the frame rate will drop. I am repeating, with increase in the depth, the frame rate will drop. So this is the optimal depth over here. How much should be the depth? That is discussed in the class. So this is the depth, and this is the focal zone, which is near the area. This is my interest. That is why I am even seeing the vitelline duct over here. And the probe used is transabdominal probe. And the things will be 100 times more clear on TVS. But the basic important point is set your machine. You should know which knob is for what. At least you have to keep an eye on the frame rate. Then frequency also. Then the focal zone. Go back to the physics and machine settings. If it is deactivated, call us. We will reactivate. Please complete the physics and machine settings before attempting any gynae, fetal, abdominal ultrasound. So this is the thing why we are taking physics and machine settings first. Because first you have to set the machine, then you have to play with these knobs, at least the basic ones. So again, now see, in this case, what I see over here is the yolk sac. This is the calcified yolk sac. In early pregnancy ultrasound course, we are having one class of 20 to 30 minutes on yolk sac only. And there I showed on patients how the yolk sac was looking like. Calcified yolk sac. This is the calcified yolk sac over here. Right now, we are not taking the class. We are showing you the patients also here. These clips, these pictures only. So this is the yolk sac over here. Why the picture is clear? Now see the focal zone. Focal zone is near the area. So move your focal zone accordingly. So this is all for now. Thank you very much. We'll see you soon. Bye-bye.